Buenas tardes. Creo que todos me conocéis, pero bueno, para aquellos que no me pongan cara, soy Antonio Ruiz de León. Quiero comenzar agradeciendo a los organizadores la invitación a moderar esta mesa, que creo que es una mesa con un contenido de gran actualidad. Vamos a hablar de los avances, de la valoración, de las aportaciones que el módulo de topografía, planimetría hace en las indicaciones de ENDOFLIP. Para ello vamos a contar con un experto, el doctor Armando Peixoto. El doctor Peixoto es médico gastroenterólogo, se ha formado en el Hospital São João de Oporto. Tiene un currículum, la verdad, muy amplio, más de 100 artículos publicados en revistas nacionales e internacionales. Es coordinador de la consulta de neurogastroenterología y motilidad. Es secretario general del Núcleo de Neurogastroenterología y Motilidad de la Sociedad Portuguesa de Gastroenterología y creo que nos va a hacer una puesta al día de lo que estábamos hablando, de estas aportaciones que nos hace el nuevo ENDOFLIP. Cuando quiera, doctor.
Buenas tardes. Mi nombre es Armando, soy de Portugal, de Oporto. Voy a hablar en inglés porque mi portuñol no es suficiente para hacer una presentación completa, pero espero que les gusta y después pueden hacer las cuestiones en español como quieres, está todo bien. So, I'm going to speak about ENDOFLIP, a new technology on esophagology. And we start with a presentation that I would like to be centered on patient complaints. So we are talking about motility, dysphagia, chest pain, but all of these symptoms, like in everything in gastroenterology, we have to see first to see what we can do for our patients. And C in gastroenterology means endoscopy. And this is the algorithm from the room for criteria for diagnosis of dysphagia. And the first step is always to make an upper endoscopy with biopsies. And it's important to say this because if we are going to propose a diagnostic test to a patient, we have to get as more information as we can from that exam. And that is what we are talking about in this presentation. This is an everyday routine in our hospitals. When we see a patient with esophageal symptoms, we ask for an endoscopy, but and we can have a lot of diagnoses that can explain dysphagia, chest pain, heartburn, like esophagitis, strictures, eosinophilic esophagitis, but over half of the patients will have a normal endoscopy. And what we say to the patients on that occasion is everything is okay. We have to order another test, we have to make referral, we have to make a new appointment and ask for another exam, whatever it says, so manometry or barium study. But the thing is that for a patient, this will take too long for their symptoms because we are not explaining that. So what if we could get more information from that first endoscopy? This is a provocative question, but it's something that we have to think now that we have this new diagnostic tool. Because if we have a patient that has a normal endoscopy and the suspicion for an organic or structural disease is very low, what if we can make a simple diagnosis of a motility disorder that could make the patient not going through more exams and start immediate treatment, or even get a full study with a pH monitoring, with a pH capsule, if the patient has complaints of reflux disease. This seems like a dream, I know, but we are getting closer to this. And I think that the medicine that is centering in patient has to be efficient and fast to get more information as soon as we can, so that this patient can be treated earlier and that reduce anxiety associated with their complaints. So, the question that everyone is asking now in your heads is if the flip, the ENDOFLIP that we're going to talk about, can be an alternative to high-resolution manometry. And the answer is yes, sometimes. Well, we are all familiar with high-resolution manometry. Now it's in the 4th version of the Chicago classification. What we see in high-resolution manometry is esophageal motility that is a response to swallow, so it's primary peristalsis. And we have these lovely images in which, with the principle of topography, we can have a space and time continuum of what is happening when the patient swallows. But all of the peristalsis in the esophagus is not primary peristalsis, so we can get more information if we go deep studying that motility. And that is what the functional luminal imaging probe, that we are calling FLIP, is doing right now. Another way that we can clear our esophagus is through the response to distension. Distension to something that gets stuck on the esophagus, or a refluxate that comes from the stomach. And it's very important that the esophagus has a second response to that distension to be cleared. And this is what we are going to see in the ENDOFLIP. So this is not pressure, the colors are diameters, but we can see that there is a response that goes in the space continuum time using the same principles of topography in which we can access the motility. And so we can use now both of this information to better characterize our patients. The thing is that since 2017, when the first recommendations on the use of ENDOFLIP was published in the DIAGA Association, they say that they could be used to clarify motility disorders that could not be fully explained by manometry. And the Chicago classification, in the last iteration, puts this small square together with the barium study to say that we can use ENDOFLIP in patients with AGJ outflow obstruction with symptomatic complaints to further characterize to see if it is true or not. But nowadays, in 2024, it's very short that ENDOFLIP in practice should be only for these cases. And I'll show you why. First of all, explain a little bit about the technology. The ENDOFLIP uses a catheter that has several impedance sensors. We have two types of catheters, the 8 centimeters and the 16 centimeters. The 8 centimeter was the first one to be described and what was utilized in the first version of the FLIP. But what we can study is that filling the catheter, the balloon, that goes around these impedance sensors with a saline fluid, we can access the cross-sectional area. When we talk about cross-sectional area, we are talking about diameters. And also we have a sensor, a pressure sensor in the balloon so that we can access also distensibility. That is the ratio between the diameter on each point and the pressure that is censored in the bag. The difference between those two types of catheters is that the 8 centimeters can only be used on the AGJ junction to see the dynamics of the opening of the AGJ. And the 16 centimeter uses more sparse sensors, but it can study the response of the esophageal body to distension. So we can get contractility patterns in those studies. The protocol is the same. We position the catheter transorally in a sedated endoscopy, so the patient won't feel anything, and that's one advantage comparing to high-resolution manometry. And that we fill the balloon in a stepwise manner. It depends on which catheter we are using. If we are using the 8 centimeters, it goes to 50 milliliters. If we have the 16 centimeter catheter, we can go up to 70 millimeters. And this is what we get when we fill the catheter with the saline. This is the images that we got from the first version of the flip. So we will only study the AGJ dynamics, so the cross-sectional area and the distensibility index. But with the 16 centimeters catheter, we can see that as we are going to fill the balloon, we are getting certain patterns of contractility. This is not pressure, again, this is diameters, in which the blue colors correspond to wider diameters, and the red colors correspond to narrow diameters. So we can see changes in diameter all over the distal esophagus and the AGJ junction. We have now, that is already approved in the US, probably in the next few weeks will be approved here in Europe, the 300 system that will be more user-friendly. And so what can we do with those metrics? So we are talking about the AGJ dynamics, what we can get there, distensibility index and the diameter, and also contractile pattern with the longer catheter. This is to show you, when we compare the dynamic of the opening of the AGJ junction with manometries in patients with definitive achalasia, we can see that the ENDOFLIP using cutoffs of less than 2 in distensibility index or a diameter of less than 12 millimeters, we almost never fail a diagnosis of achalasia. And most of the times when we don't reach these values, most of the times it's in a borderline area, and almost no cases of achalasia are missed when you use these dynamics comparing to definitive diagnosis of achalasia. And what can we see on the distal esophageal body? These are contractile patterns that are described at this moment. These are the normal response to distension, what we call the anterograde repetitive contractions that follows the rule of 6. There are to be 6 that follows each other with the 6 centimeters in axial length, and there must be in median 6 contractions per minute. This is a normal response. If we can see this pattern of anterograde contractions that don't follow the rule of 6, we call it borderline or diminished contractile pattern. Probably this is normal, and we include in the normal response. But all of the rest we consider to be pathologic. If we don't see any type of organized contraction, absent contractions, or a spastic reactive that can be due to spastic response, hypercontractile esophagus, or sometimes cases of achalasia. And when we mix the AGJ dynamics with the contractile pattern, we can start to make some diagnosis, or more well said, we can define more what is clearly abnormal if the AGJ function is impaired in its opening, and what is clearly normal if the AGJ opening is above the threshold that are actually validated, and we have a normal anterograde repetitive contractions on the panometry. And how does this compare to manometry? This is very important. These are symptomatic patients that were submitted to a flip panometry. Panometry is a term that we use when we had the contractile pattern to the AGJ opening dynamics. So this is the classification of the flip study. When we have symptomatic patients with a normal study on the ENDOFLIP, this is what we get on manometry. So no cases of achalasia are missed. And most of the cases that are not defined as normal are related to outflow obstructions that are falsely positive or ineffective motility on manometry that, as we all know, most of the times correspond to a normal motility pattern. What is more intriguing is that when we compare a normal flip with manometry and compare it with asymptomatic volunteers that are submitted to an high-resolution manometry, it seems like the pie is the same. So if we have patients that are symptomatic but with a normal pattern on ENDOFLIP, they are like asymptomatic patients with normal manometry. And so with these findings, there's been an effort to try to make a diagnosis or try to screen the patients to see if we have to do something more after an initial endoscopy with an ENDOFLIP study. Clearly, we have data that show us that a normal ENDOFLIP, so a normal AGJ opening with a normal contrailed pattern, probably we don't get anything more from manometry in most of the cases. And the same can be said about achalasia. If we have an obstructive pattern without a normal contractility, probably those patients have a clear achalasia, and so in those cases, probably we will not change our management of the patient if we get an high-resolution manometry, and we are just going to delay further treatment. So if a patient has a normal ENDOFLIP, probably we are talking about symptoms that are derived from reflux disease or functional problem. If the patient has a normal opening but a weak response to distension, probably are talking about patients with difficulty in clearance of the esophagus, so patients with reflux disease, in which cases, if the patient is not going to be proposed to anti-reflux surgery, probably we don't get anything more from high-resolution manometry. However, as I said previously, there is a gray zone in which we have some spastic or reactive patterns in ENDOFLIP that are not very well characterized. In those cases, we surely have to have an additional test to confirm the diagnosis or to see if there is another diagnosis that was not well seen in ENDOFLIP. And so high-resolution manometry will be essential on those cases. There's also been an effort to try to make a similar classification using the patterns on ENDOFLIP and compare that with what we have on the Chicago classification of the motility disorders. But we clearly now are more focused on what is clearly normal and what is clearly pathologic. When we look retrospectively to patients that were submitted to an high-resolution manometry and submit those patients to an ENDOFLIP, we surely get those best results on normal tests or no clearly pathologic tests with obstruction and a weak contractile response, in which almost all of the cases are detected on ENDOFLIP. So in those cases, probably we can defer high-resolution manometry if the management will not change with that result, and reserve the high-resolution test that we must say that is a test is not so friendly for the patient. It's very more difficult to be done because the patient is awakened and has a foreign body in his nose and pharynx, and so we have to try to reduce those type of procedures if we don't get any further information. And there's also situations in which symptomatic patients are submitted primarily to an high-resolution manometry, so they follow the algorithm of obstructive symptoms, and they get normal pattern on motility. But if I tell you that in 1/3 of the cases we can get a pathologic result on ENDOFLIP, it's because probably some of the patients that we don't get the answers for manometry have problems on their secondary peristalsis. And so this is not an alternative, but in this case, a complementary study so that we can further comprehend our patients and look for some type of treatment. We are talking about, most of the times, problems related to the AGJ relaxation. And it seems, it's a study from this year, that starting with an endoscopy, with an ENDOFLIP to screen for a major motility disorder and then get a further test like an high-resolution manometry is more effective than going through new appointments, new referrals, until they get their high-resolution manometry done, mostly in patients with a low probability of achalasia. So, in clinical practice, how can we use this information? Well, it's very clear that in patients with outflow obstruction or manometry, we get a new information from ENDOFLIP, because most of the cases it's a false obstructive pattern in which there is a response to the distension with the balloon of the ENDOFLIP, and so this correlates with a normal barium study, or we can confirm the diagnosis of obstructive disorders like achalasia. And this is important because it has some treatment associations. If there is a normal AGJ opening on ENDOFLIP and we treat the patients with conservative measures, we'll have a good response comparing to patients with a conclusive obstruction on ENDOFLIP, in which if we use achalasia type treatments, the patient will get better than with just watch and see. Another thing is, how can we predict the type of achalasia? Because different treatments for different types of achalasia, as we all know, mainly for type 3 achalasia, in which cases POEM is the best validated therapy. But if you use a machine learning prediction model that is supervised, we can reach up to 90% of the cases with spastic contractions on manometry. And so even in these cases, we can make a full diagnosis based on ENDOFLIP and then refer the patient directly to treatment. Also, during the treatment of achalasia, during myotomy, we can ask for the sweet spot. Can we do a myotomy that is good for relief of dysphagia and not getting reflux? Probably yes. And the majority of the evidence today is for POEM. This is a study in which most of the cases with ENDOFLIP were submitted to an additional myotomy during the POEM procedure. As you can see here, the results were better on the patients in which cases we use ENDOFLIP during POEM procedure. After treatment, that is the most of the cases, if the patient comes back to us with new symptoms after a myotomy, in these cases, clearly the ENDOFLIP outperforms the manometry. The evaluation of the sensibility index is much better than the IRP or the basal pressure on the lower esophageal sphincter. And so this is the test that we have to order if a patient with achalasia had a previous treatment to see why he is getting new symptoms and if it is needed to have a new treatment. And eosinophilic esophagitis, we have for about 10 years this concept of the dissensibility plateau, in which cases, even if we fill the balloon with more fluid and increase the pressure, there is a point in which case the diameter will not increase because of the fibrostenotic remodeling of the esophagus. And this has been shown to be related to symptoms, to severity of symptoms, risk of food impaction, and need for dilation. And this is much better than the correlation with the eosinophilic counts, in which cases there is no correlation with those type of complications. More recently, there was an effort to try to phenotype patients with EOE based on the ENDOFLIP results. As you can see here, patients with a longer disease, but mainly patients with restrictive opening of the esophagus and that lost the normal pattern of the motility of the esophagus, have more symptoms and a lower response to PPIs. In reflux disease, we don't have so much information about the role of ENDOFLIP in defining patients with more or less risk of getting reflux disease, because there is not a clear correlation between the opening dynamics of the AGJ and the exposure of to acid. These are two different studies with different conclusions, but there seems to be a correlation that has been shown in several studies with a normal contractile pattern in secondary peristalsis, so the clearance of the esophagus, and less exposure to acids. We can also tailor the fundoplication, being that in surgery or endoscopic, with ENDOFLIP to reduce the symptoms of dysphagia and bloating after the treatment, and at the same time getting the reflux controlled. And early this year, there was a publication that I think it's very interesting, because a lot of the times we can get a definitive diagnosis of reflux disease by just getting an endoscopy without PPIs. If the patient has a grade B, C, or D of reflux esophagitis, we can get the diagnosis from that endoscopy. So they thought, if we can access motility, we can refer patients for surgery on the first endoscopy. And the ENDOFLIP in these studies showed a sensitivity for esophageal dysmotility of 95% and a negative predictive value for major disturbances on high-resolution manometry of almost 92%. And so the authors proposed that in patients with a clearly diagnosis on the first endoscopy of reflux disease, with a normal study, they could be referred directly to anti-reflux procedure. Of course, as I said in the beginning, this is not a dream. ENDOFLIP has limitations, as a resolution manometry and the other devices that we use to study motility in gastroenterology. And so we have to know them. And one of them is a lack of an analysis software that makes us necessary to make the interpretation on real time. And there is some differences between centers on the protocol that is applied. And so, to finish, the ENDOFLIP is a well-established esophageal motility tool nowadays, for those who are lucky to have it in their armamentarium. So we can complement the study of patients with esophageal symptoms. And we have to divide these patients in two types. The patients that have a normal endoscopy, and in which we can make a screen for major disorders, or make a screen for a normal motility on ENDOFLIP, and so we can refer the patients to treatment directly, or probably discharge them from more motility tests. And also in patients submitted to treatment, the ENDOFLIP has been shown to be very useful to tailor the treatments and to evaluate relapse of symptoms. Thank you for your attention.
¿Preguntas? No me puedo creer que no tengan preguntas. Yo estoy lleno de cuestiones, pero ahí tenemos Cecilio.
Congratulations and thank you, Dr. Armando Peixoto, for your presentation.
¿Puede ser en español, Cecilio?
Mejor.
El problema es mío.
Mejor para mí. Nada, te estoy queriendo decir, yo creo que cada día esta técnica aumenta y nos da soluciones a muchos pacientes. Tú has ido nombrando en qué pacientes concretos. Y la pregunta que yo te haría es, ¿quiénes deben intentar tener la formación, aparte de adquirir los equipos, y ojalá reduzcan los precios, para poder resolver a estos pacientes? Me refiero a si esto es en las unidades de motilidad o deben ser todos los endoscopistas que puedan tener a la mano el ENDOFLIP para resolver sobre la marcha, quizás sin despertar al paciente de la sedación.
Claro. A ver, con los datos que tenemos ahora, es posible de entender que todos los servicios de aparato digestivo van a tener una herramienta de cribado, de que puede ser una dismotilidad importante del esófago, porque el costo del procedimiento es más bajo que tener citas y una manometría y todos nosotros que nosotros que hacemos la manometría sabemos que en español the waiting list para hacerlo es muy grande y la manometría es más difícil de interpretar. Yo pienso que es más difícil porque tenemos más datos, hay más variables y por eso la interpretación no es solo lo que tenemos en el ordenador, pero las dudas que el paciente nos coloca es muy importante en la interpretación. En ENDOFLIP es más directo, es normal o no es normal. Y si es normal y el paciente tiene una baja probabilidad de tener una calasia, probablemente no vamos a tener algo de importante. En los otros casos podemos hacer una referenciación para el centro terciario para hacer una nueva evaluación, hacer una manometría y tener más respuestas con eso. Sí.
Los datos económicos es que no nos valen, porque una endoscopia en Estados Unidos tiene un costo aproximado entre 2.000 y 3.500 euros. En España, en Portugal, es casi 10 veces menos.
En Portugal
Por tanto,
es 20.
extrapolar, sí, esos son datos que los pueden contrastar todos en Internet. Es tan fácil como pedir precios. Tienes precios en Canadá, en Inglaterra, en Estados Unidos, en todos los sitios. Con lo cual, es muy difícil, desde el punto de vista económico, encajar algunas cosas. Yo creo que a mí lo que más me choca de todo esto es que ya lo viví cuando pasó con la pH-metría y la impedancia, la idea de que tienen que ser enemigos, cuando realmente son dos técnicas completamente diferentes que valoran de forma diferente unos aspectos que son parecidos, pero no son iguales. Y yo creo que, mi opinión, a lo mejor estoy equivocado, incluso ahora mismo en la Universidad de Northwestern están dando un poco, replanteándose el tema. Y de hecho ha salido un artículo en Neurogastroenterology Motility hace un par de meses, creo, no más, en donde se han planteado y empiezan diciendo, son dos técnicas en donde encontramos resultados que muchas veces son diferentes y que son complementarios. Y por tanto diseñan un programa que realmente estudiárselo en el paper no es fácil, en donde intentan unificar criterios de uno y otro. Y empiezan a decir, podemos aprovechar dos cosas. Yo creo que ENDOFLIP, en mi opinión, y yo no soy aquí el protagonista, que es usted, pero quiero decir, tiene muchas cosas buenas. Quizá, para mí, lo mejor es que pone objetividad en algunos aspectos. En aspectos endoscópicos, pero también en aspectos quirúrgicos, y eso es muy bueno. Porque todos estamos acostumbrados a ver en los informes de endoscopia muchas veces que dicen dificultad al paso por la unión esofagogástrica. Bueno, ¿qué tal grado de dificultad? Con ENDOFLIP te dicen distensibilidad y te da un valor. Zona estenótica, pero pasa el tubo, no sé qué. Oiga, mido el diámetro. Por tanto, estamos añadiendo objetividad. En la cirugía o en el POEM, estoy haciendo un POEM, no estoy seguro de si he llegado a todas las fibras que tengo que seccionar, hago un ENDOFLIP y si veo que me he quedado corto, continúo. Perfecto. Estoy haciendo una cirugía antirreflujo y ahora muchos cirujanos no hacen con un fiador la calibración del cierre de los pilares, pero si la quieres hacer, mejor que con una cosa rígida, con una cosa que te está midiendo qué tal presión estás añadiendo a los pilares. Y a mí en eso me parece muy bien. Pero comparar desde el punto de vista de motor, motilidad por manometría con ENDOFLIP, yo no lo veo, perdóneme. Pero no lo veo y voy a decir por qué. ¿Dónde vemos una regurgitación? Con ENDOFLIP es imposible. Y como eso, 27.000 cosas que da la manometría que no las puede dar ENDOFLIP. Pero es que no significa que sea peor, es que es otra cosa. Entonces, a mí me parece, y no quiero alargarme mucho más, porque creo que lo importante es que sea...
A mí me gustaría preguntarle cuánto tiempo tardas en hacer el ENDOFLIP a tus pacientes.
Menos de 10 minutos. La cuestión es que todos nosotros que hacemos manometría, hacemos mucha manometría en pacientes con muy pocos síntomas, en que la probabilidad de tener un disturbio es muy bajo. En dos pacientes están en la lista de pacientes para hacerlo y muchas veces tenemos pacientes que tienen miedo que hacer una manometría y van a tardar en hacerlo porque andamos a hacer manometrías a pacientes con el bajo riesgo de tener una dismotilidad que es importante. Y en esos casos el ENDOFLIP es muy bueno porque si el ENDOFLIP es normal y el riesgo de tener una calase es muy bajo, nosotros podemos verlo. Si no hay una dilatación del esófago, si tiene un estudio variado que es normal, la probabilidad de tener un disturbio mayor con un normal ENDOFLIP es muy, muy bajo. Y los pacientes se quitan de la lista de manometrías. Y son muchos pacientes esos.
Probablemente lo vemos desde perspectivas económicas y sociales diferentes. Yo creo que en nuestro servicio, cuando estábamos, no teníamos una gran lista de espera de manometrías y evidentemente se hacen manometrías a pacientes que no las necesitan, pero endoscopias también. Sí. Endoscopias también. Quiero decir que, bueno, en ese sentido, pues vale, pero insisto, yo creo que es que plantearlo como mecanismos antagónicos no es, en mi enfoque, no es lo ideal para que las dos técnicas avancen, ¿no? Sí, que no te veo con la luz.
Sí, gracias. Thank you very much for your very interesting talk. Brilliant. I would like to make just one or two comments. ENDOFLIP is a fantastic tool, but we have to keep in mind several things. First, most, if not all, the publications come from the same group.
Yeah.
From Chicago. And we have to keep in mind that there is a huge conflict of interest because the Chicago group, they are very clever people, they are very nice people. I know them very well, but they have the patent of ENDOFLIP. And they have published 99% of the papers on this technology. So maybe we have to wait a little bit and see whether other groups can reproduce these fantastic results. My experience, it is the second comment, my experience with ENDOFLIP is that I use it every day. It costs a lot, 300 euros per balloon, single use. It's 300 euros per balloon. It is sometimes very difficult, and as for pH monitoring, as we said this morning, there is a gray zone. I'm doing ENDOFLIP for all my achalasia patients. And for example, the threshold of 2 for distendability index, sometimes you feel very uncomfortable. For example, with a patient who have still dysphagia after a POEM or after a surgery, you perform an ENDOFLIP, it is 3 or 4. What are you doing with that?
Yeah.
I don't know, and nobody knows.
Yeah.
So, and high-resolution manometry doesn't give you the answer, neither. I fully agree with that. Yeah. So it is a new tool. We have to learn how to use it. We have to learn how to manage it and to include it in our algorithm of management. But in my opinion, it is my opinion, in 2024, it is a little bit early to say that it could replace high-resolution manometry.
It was a provocative presentation. You must know that I don't have any royalties with the selling of ENDOFLIP, so.
Muchas gracias por la presentación. Yo estoy de acuerdo con el doctor Cervi. creo que, sobre todo cuando, bueno, primero con el tema de las publicaciones, es verdad que la mayoría de las series de casos son del mismo grupo y luego cuando se intenta otro grupo publicar a veces hay dificultades para llegar a publicar en ciertas revistas. Eso por un lado. Y luego es una herramienta que si el software, que en nuestra experiencia falla tanto, que ya estemos intentándola incluir y sustituir otra herramienta que está bien establecida como la manometría en la práctica clínica, me parece un poco, pues como ha dicho el doctor Servit, temprano y a lo mejor arriesgado. Yo no sé si a vosotros os pasa, porque nosotros hemos probado el software en abierto de Chicago y hay muchos estudios que no los podemos analizar, que nos da error, no llegas a 60 mililitros, se desplaza el catéter y entonces el esfínter se va arriba y tampoco te lo permite analizar y te dice que lo vuelvas a meter. Entonces, claro, yo cuando veo que publican 800 endoflips que han hecho y sacan unas conclusiones y me ponen una tabla que ya sustituye a la manometría, hombre, pues me cuesta un poco creerlo. Y luego es verdad que fuera de las explicaciones y demás, cuando dices, ¿y en estos pacientes qué hacéis? O pides algún otro tipo de explicación, no son claras las explicaciones. Entonces yo no sé, sobre todo la pregunta ya fuera del comentario es respecto al software, tu experiencia, cómo lo haces, cómo haces el análisis.
Sergio, una cosa ya, y me están haciendo señas que vamos muy mal de tiempo. Quiero decir que, de todas maneras, el software el software que viene no tiene nada que ver, porque sale un equipo nuevo, por cierto, que ya hace informes, y entonces habrá que ver lo que da. Yo no lo conozco. Lo conozco por lo que he visto así por encima. Pero quiero decir, no sé lo que da. Pero lo lamento mucho. Yo creo que nos quedan muchas cosas ahí pendientes, pero nos hemos pasado de tiempo y no quiero quitarle más tiempo a los que vienen detrás. Muchas gracias.
Gracias.